So our next speaker is Dr. Vardhaman Kankarya, specialized in cataract, cornea, and refractive surgery. He is the first to get the dual fellowship internationally with great skill sets and awards and accolades to his repute. He was the secretary of the Maharashtra State Ophthalmic Society and leading the society with great vigor. He has his own teaching pearl for us today. So over to you.
Thank you, Dr. Anaga, for the kind words. And thank you so much, Dr. Chitra ma'am. Am I audible?
Yes.
Yes, thank you. So, yeah, when Dr. Chitra ma'am told me about difficult movement in refractive surgery, I think recently we had a movement which I would really say is a difficult movement. Not only, yeah, 1 second. Yes, so for this patient, the patient was actually scheduled to undergo a femtosecond Lasik procedure, and this was the flap which was being made. This is the first eye of the patient, which is the right eye. And I think the clarity of the video is okay. Yes, sure. So the right eye of the patient, and as you can see, the cavitation bubbles are being formed, and we are creating the lenticule very well. Then there will be a side cut which is being made. And we got actually a shock of our life when this flap was made, because in this position, the table of the Visumax got stuck. So basically, the table of the Visumax got stuck, and there was an unknown technical failure which occurred in what they call as a rotating patient support system, which is essentially the operating bed which goes between your femtosecond laser and examer laser. And this got stuck at this high position. So we called up those eyes technical team for their advice, and they said that you should probably switch off the laser once again. There can be a minor glitch somewhere, and switch it on. And we tried it almost 4 to 5 times, and then this wouldn't work at all. So as you can see on the right side, there was this information or error which came, and then we realized that there was a part of the motherboard of the table which had actually gotten conked off. And this is during the COVID times. So basically, we were not sure whether they will have the part in Bangalore again. And we had a lot of challenges because the time required to resume functioning of the laser assembly or the table bed was not sure. We couldn't even proceed because even if we have to do the flap lift and do the examer ablation, we require the same bed to be functional. So we had to essentially abort this case. So the question was whether the primary flap lifting can be uneventfully done after few days once this becomes functional again, and would it be possible for us to relift the same flap, or we will have to actually do something else. So we thought that we will of course wait for the assembly to start, and we thought that we had few options such as primary lifting of the same flap if possible after a week or 2 weeks whenever this is available, or creating a new flap with a larger flap diameter at the same depth or maybe deeper, creating only the side cut inside of the primary flap, or doing a surface ablation because this was primarily a -3.5 spherical refractive error. Finally, the functioning of this stable assembly was restored after 1 week, after the part was restored from Bangalore. And so when we saw the patient back, we actually did a lot of literature search to see if a primarily unopened flap can be lifted back, because we always know that if you have lifted a flap in femtosecond laser or a microkeratome Lasik, you can relift it even after 10 years. But for a primarily untouched virgin flap, it's possible to relift it, was the thing that we wanted to see. And when we saw the patient back, you can see a very thin line of this side cut, which was still seen. So we decided actually to attempt to open the same flap after a week. And then I had marked the age of this flap, as you can see in the lower right corner photograph. So this is the video when we have opened the unopened flap after 7 days. And you can see here, I'm going to make an attempt to find the side cut of the flap. And with almost the second attempt itself, you can see that I could actually find the flap, and this is the mark of the flap edge that we could see. So once the flap edge was found, of course, we could proceed as normal, and fortunately, we could perform the surgery successfully. This is immediately after we had done the ablation. You can see this is the mark, and this is where we had attempted the first entry. The patient, of course, recovered very well and is under follow-up for more than 2 months now and is doing extremely well. This is basically just to take home the message that intraoperatively technical failure can occur anytime, and the primary flap lifting can be done even after 1 week of this laser application. At least from this case, we could know that. So there was this second short case I would like to present. This is a 41-year-old male who had progressive diminution of vision for almost 6 years. He had undergone Lasik 8 years ago in some other center in the neighboring state of India in Gujarat. And his left eye was doing extremely well, but in his right eye, his vision was actually pretty bad. It was finger counting 3 meters, and he has had multiple attempts of epithelial growth management in the past. As you can see on the slit lamp, there was a very big chunk of epithelial cellness involving, of course, the visual axis, and the vision was down to finger counting. On OCD, you can see extremely thick epithelial ingrowth, and it was almost way more than 4 millimeter in its extent. And there was a lot of flap fibrosis, and the epithelial, you can see the topography had become extremely irregular. So, of course, I had the opportunity to manage such a case in like under my mentor during my fellowship, which we had published back in 2011. And now back in 2018 or 19, when we had dealt with this case, actually, that case handling came to our help. And what we decided to do was that we decided to actually ampute this flap, because there is no point of relifting the flap and then removing epithelial growth, scraping it, or using mitomycin C or alcohol, because there is so much of fibrosis at the flap edge that this flap ingrowth is going to come back again and again. As you can see, I was finding it very difficult actually to dissect the flap. Also, usually the flap lifts are extremely easy. Here you can see there is this fibrosis, which was making it very difficult for me to dissect the flap on that edge. I had to actually take a small vanas and then uh, basically have a small nick at that edge to remove this flap. So you will see that now. Yes. So now this flap was lifted, and of course then it was amputated. Once the flap was amputated, we did a thorough debridement of the epithelial cell nests from the surface. And once that was done, we used plenty of mitomycin. We used mitomycin C to reduce the possibility of haze. And then at the end, we put the patient on a bandage contact lens. So yes, this is the bandage contact lens in place. So this is the picture that you see almost 2 months following the procedure. This is the pre-op and the post-op. You can see there was a minimal or no haze on the surface. The vision improved from counting fingers to CDVA of almost 6/9 with a myopic refractive error, but the patient was extremely happy because he got his vision back. Thank you very much for your attention.
Thank you very much, Vardhaman, for the two situations which you showed us. So, of course, the message to the attendees is that if you're sure your flap is devitalized, that would be the only situation where you would discard the flap, as in this case, but you would not do it because you could end up with some hyperopic shift. The other important point we learned from his presentation is when you throw out the flap, you should not think that there is no interface, so there's not going to be an epithelial growth, and you do not use mitomycin. Mitomycin has to be used to prevent the scarring. So, expert panel, do you have any thoughts to add about any other way of dealing with epithelial growth?
Chitra, can I?
Yes, Rupal.
So, Vardhaman, very nice presentation. The first case, if you had any doubts, why did you not just lift the flap and leave it as it is? You could have done it under any surgical microscope.
That's true.
So that was a simpler way.
Right.
Because, rather than remaining in a dilemma, but a very good point came out that you can actually lift the flap any other time. So that was a good thing that came out of this. For the second case, why do you think you got a myopic error, -3 with -1 cylinder?
Right, ma'am. So actually, that was a bit of counterintuitive, because as if the flap is planar, like what we would have with femtosecond laser, probably we will land up very close to the plano in spite of having the flap amputation. But I think in this case, probably a microkeratome was used, and microkeratome gives rise to meniscus shaped flap, which are much thinner in the center. So maybe when you take out the flap, you will have probably a slightly more convex cornea which remains behind. I mean, that is the only explanation I could think of, because the patient ultimately landed for about -3 diopters of myopia in this case. So I think that may be because of the meniscus shape of the flap, which was made with a microkeratome.
You should not cause so much of myopic error.
I agree, yeah.
And you didn't have any haze. So
Yeah, very little on the surface, I will say.
Can I add, Vardhaman, in this particular case, because you have removed the tissue, the flap, and the corneal thickness may be around 300 in this particular case.
Right.
So there would be some sort of curvature change happening. So your cornea would have become steeper because of thin cornea, and that will add into your myopic refraction in some patients. So this cornea ultimately may become ectatic.
Right.
Other option in such cases of where you feel the flap is not healthy with this type of disorder, people have done lamellar procedure also to make a corneal thickness better and have a better contour and have a better refraction. And after you do a lamellar procedure, if you have some refractive error remaining, people have done a surface ablation on that also.
Right.
So those can be done.
I think possibly of
Vardhaman, just a couple of comments.
Yes.
Okay.
Was there.
Okay. See, this has happened to me also, where the bed gets stuck. Okay.
Right.
And if that happens, switching on and switching off the mains does not help.
Right.
You hit the emergency button. There's a red emergency button. You hit that, and then you can actually move the bed, and you can safely get the patient out. The second is routinely in bioptics, we make the flap. We don't lift the flap. We do the ICL, and then after 3 weeks, we can easily lift the flap and do the ablation. So that's not a problem. I mean, finding the flap and lifting it, we do it routinely.
Yes.
So that is not an issue at all. And in the second case, probably in such cases of recurrent epithelial ingrowth, usually there's a fistula. So what you have to do is identify this fistula, remove the epithelium, and then put in glue and then suture it. And if you do that, then the fistula gets closed. So you don't have the recurrence. So probably that could have been tried before amputating the flap. Yeah.
Right, sir. I think so. If a quick comment. So in the initial, like a similar case we had dealt with, it was with Professor Kimionis in the past. And at that time we had actually tried to put the sutures and remove the epithelial ingrowth, as you had correctly said. And still there was even more aggressive ingrowth which had come in. And in this case, it was so huge. I mean, when I looked at the slit lamp, I was actually amazed. I had never seen such epithelial ingrowth in my life or in any presentations and all those things. So we were very sure that there is no other way to go about it, right?
You can also have some amount of corneal melt when you have a large epithelial nest. So that could be the reason for your myopic shift, because meniscus flap will not give a myopic shift. Usually you get a hyperopic shift once you amputate the flap. But if there is some amount of a kind of a melt which has happened, and this was a fairly large area, and that could kind of reduce the thickness there and give rise to a myopic shift. That's what I feel.
It was all over.
Yeah.
The whole epithelium.
Yeah.
Stromal ablation, stroma would be melted all over, especially in the center.
So it gives a
cause
myopic
more
shift.
hyperopia.
Yeah.
Because in that
Belts normally give hyperopic shift.
It should give a hyperopic.
It was in the
not a
periphery. It was
myopic
in the
Yeah, I understand.
periphery.
It's going to be very difficult to have just a melt in the periphery. That's pretty, maybe it's.
But with the kind of epithelial ingrowth that is there, at least one try, I think, should have been given with, flap lifting and mitomycin C, and then seeing how it goes. And I think, Vardhaman, in your first case, the greater challenge is when the machine stops in between the ablation. You've just done 25-30% of the ablation and your machine stops.
Right.
Then it becomes a greater challenge.
Yes.
Because then you don't know what to do. Then the only thing which the manufacturer taught us when we had it was that you take that much amount, 25% or 30%, whatever you've missed out on a plate, on a fluence testing plate, because the treatments are not equal, and then take the rest of it on the eye.
That's right. When the examer laser has that issue, you can do that. So in this case, unfortunately, both the lasers were perfect. It was only that cable which had this issue, which is very unfortunate.
So thank you very much. We need to give justice to all the other speakers too.